I have no disclosures. So this is a slide that we're all very familiar with. And interventional radiology, usually we think of treating patients with the intermediate stage cancer, and that's only about 20% of the patients. Interestingly, there's been a study, the Bridge study, and this showed that globally, almost 80% of patients treated for HCC were outside of those guidelines. And similarly, in another European study, 40% of their patients were outside of the traditional guidelines recommended for TACE. Now, we all know that the natural stage is to move from left to right. However, there is the newer concept of stage migration, where you actually downstage the patient. So I'm going to talk about the indications for TACE in the different stages, not the intermediate stage, but stage 0, stage A, stage C, and so forth. And I'll give you some examples. So these are starting with stage 0 and stage A. So here we have a lesion, and the reason why this hasn't been ablated is because it's in close connection with the adjacent bile duct. And obviously a biliary stricture from thermal ablation would be catastrophic and he'd require lifelong drainage. So this was a suitable patient for TACE. As a bridge to transplant, which is something we do in Shifa, and it's mainly because of to help with the waiting time, and studies have proven that there's improved post-transplant overall survival. TACE and ablation. So for lesions which are between 3 and 5 centimeters, this is now one of the recommendations, and when we get a much better result, both in terms of recurrence-free survival and overall survival. Now, if I go for indications for TACE in the BCLC-C category. So again, intolerance of systemic therapy, which is quite common, liver dominant, ECOG1, and some other examples. The only thing is, the caveat is that there should be a MDT discussion before taking such patients, and that is how we manage these patients in Shifa. These are just some of the side effects with sorafenib. And we can see that the side effects are quite common. So patients obviously who can't tolerate systemic chemotherapy. The other problem is with ECOG. While it's a very good differentiator, for example, ECOG 0 and ECOG 1. ECOG 0 says that you have to be able to perform strenuous physical activity. But what about if this 60-year-old guy is an office worker? You know, maybe he can't perform strenuous physical activity anyway. So, you know, PSO and PS0 and PS1, you know, it's difficult to differentiate. Another special indication, so whenever you have a ruptured HCC, it doesn't matter what the bilirubin is, you would proceed and you would embolize. This is another patient who's actually bleeding into the biliary system. So again, he's having a chronic drop in hemoglobin, so he was also embolized. The first patient, he had a high bilirubin, and following embolization, the bilirubin actually did go up as expected, but then it did return to baseline levels. So the stage migration concept, is it a violation of the guidelines? No. Choosing a different treatment is okay. We can migrate from left to right. Well, usually it's left to right, but we can go from right to left. But the MDT discussion is mandatory. TACE and immunotherapy. So conventionally, we've been using the tyrosine kinase inhibitors, and we have a significant side effect, as much as 80%. So we know the side effects are much fewer with immunotherapy. The only thing is that as a monotherapy, the response rate is only 30%. So what we advise, if you've got a large HCC, especially in the palliative setting, you're better off embolizing it first, releasing all these tumor antigens into the bloodstream, and then giving them a few cycles of immunotherapy, because you'll get a better response. So it's about combining the two modalities of treatment. I know my other colleagues will go over that in more detail. Just two other examples. So this is a patient who presented in July 19. Unfortunately, this is his initial presentation, and you can see this lesion sandwiched between the middle and right hepatic veins. This is the same patient going further down, and the same patient. I don't have images of his microwave ablation, but we did a microwave ablation, and then a few weeks later, we did a conventional TACE using lipiodol. So the white material you can see is the iodized oil. And we achieved a complete remission. So he was absolutely fine. He then presented in May 2021 recently, and you can see the slightly whitish area centrally near the ablation zone. So he's now got recurrence sort of 2 years later, and that's where the arrow is. And he's also developed a new lesion more posteriorly. So the lesion, this is actually not May. This should have been August 2017. So I used alcohol on this occasion, and this was the chemical ablation. Now, the one posteriorly, you could argue we could have done with RFA or microwave, but the one centrally over here, this was not amenable to thermal ablation. We've got the left and right hepatic ducts coming in. This is a very high risk, no-go area. So conventional ablation is not an option. These central tumors are very small feeders from the arterial supply. And getting rid of it completely on TACE, on standard TACE, would be very difficult. So we did chemical ablation, and you can see the image on the left. You can see that lesion is completely disappeared. The one on the right shows the posteriorly, you can see the tumor. And similarly, again here, the one on the left showing complete response, and on the right, you can see where the lesion was. So this was with CT-guided alcohol ablation for when you want to target people. The guidelines say you can use it in up to 2 centimeters. Previously, they used to say 1 centimeter. So it has to be very focused. This is another patient. Sorry, this one should have been August 2017. So this patient, he's got reasonable liver function, but his AFP was more than 30,000. He's an ALB grade 2. His platelets were okay at this time. Subsequently, following sorafenib, he dropped his platelet count to 29,000. So his PALB score would have been even less. And the CLIP score, which is supposed to give you an overall survival for general populations, but it's not very good for individual patients. But this guy was only going to live 4.5 months. So that's August 2017, not May 21. So he has a large arterial portal shunt. So that's the first problem. So here you've got the angiographic phase images, and as we inject contrast, you're not seeing the tumor very, very well, and you're seeing filling of the portal vein. So the first thing was to try and identify and find the particular shunt, the actual vessel, and this was done without the use of a microcatheter. So this was where the shunt was, and you can see that that's the shunt filling the portal vein. So the first step was to close the shunt. Following that, he had a conventional TACE in October, and now you can see the tumor much better, and we've gone in via the right and left hepatic arteries. He then has another 4 sessions of TACE in between. He was on sorafenib, that was stopped because of his play. He dropped his counts. And in his March 2021 CT, he's got no measurable disease. And he also actually had portal vein invasion. So we had, not only did we have a shunt, we had portal vein invasion, and we had a large tumor. And his AFP is 2.2 at the moment. So he's done very well. The only reason he didn't want to go for transplant is he had a minor stroke, and there were some affordability issues. Now, just briefly touching on the role of TARE in HCC. So first of all, what is radioembolization? So radioembolization is the same as TACE, except that the embolic used is a Y90, which is a beta emitter. But the principles are the same. You have to get into the vessel, you have to target the tumor. So there are lots of synonyms: CERT, TARE, Y90, and the 2 companies that make them are Cerspheres or Theraspheres. So this is, it's the beta, so it's a beta emitter. So this is just showing the penetration. So they only travel for 2 to 3 millimeters on average. They can travel up to 12 millimeters. So when you deposit them within the tumor, it's a very localized deposition. And over here you can see, like, this is the maximum range is 11.4 millimeters. It's actually much less. Now, this is an important slide because some of the negative data that's come out in some of the studies up 2 years ago in the Cervinib and the SARA trial, and that's because they argued that there wasn't a sufficient dose given into the tumor, and that's why the response wasn't good. So it's important to get the dosing correct. And this is just showing, again, the range, the median range is about 2.5 millimeters. So the concept of CERT is to selectively target a very high radiation dose to the tumors within the liver by minimally invasive means of a microcatheter. These are actually very small in size, 32 microns. So the smallest embolic agent we have in our conventional interventional radiology suite is around 50 to 150, and we sometimes use that in prostate embolization. So this is actually smaller than the conventional embolic agents that we have. Half-life 64 hours, that's from the factory. So within 64 hours, it has to leave the factory, get on an aeroplane, clear customs, and get into the hospital. And that's the rate limiting step. This is just showing the passage through into the arterial circuit, but it doesn't actually cross the capillary bed. The image isn't completely displayed here, but it would have showed that it gets stuck on the arterial end and doesn't migrate across. Okay. So the practical use of CERT in HCC. All right, so in early stage prior to radical treatments, so to downstage as a bridging therapy for liver transplantation. I think one useful thing is as a radiosegmentectomy, because you can then actually get hypertrophy of the future liver remnant. In intermediate to advanced stage, especially when you're dealing with portal vein thrombosis, which was one of the initial indications when you've got vascular invasion, about 10% of patients don't show a response to TACE. The advice is that you give them another TACE, and if they still don't respond, well, that's the literature. 10% don't actually respond, non-responders. And this is sort of roughly where you would fit CERT in. So you've got it in the early stage, and you've also got it in the intermediate stage, and even in stage C. There are lots of different studies showing good response, and we can't go into them in any detail, but certainly even you've got better overall survival and tumor-free survival. What I will come on to is over here. So these were the 3 trials which were basically saying that TARE isn't very good. And subsequently, there's been some more research done, and the Dosisphere study. And what they basically said was that they weren't giving sufficient dose. The other thing is that in the trials, those patients who were taking sorafenib were on the 800 milligrams, sort of the BD dose, which we know often a lot of our patients are unable to take. And so there are new guidelines coming up, and this is from the Lancet recently. And saying that basically is if you get the dose correct, you'll get a much better result. On another note, most of the TARE cases I did were actually in non-cirrhotic. So especially when you're dealing with metastatic disease, you can get a very good result because you don't have the problems of liver function. So most of our cases were colorectal mets, but you can also do it in breast cancer mets, in cholangiocarcinoma. The one problem with TARE is that the bilirubin cutoff is 2, not the conventional 3. So you do need to have good liver function. So when you're dealing with cirrhotic patients, that's just one of the considerations to bear in mind. And this is my last slide with 2 seconds left. So positive randomized studies in overall survival. New trials are ongoing. It's very promising. And not only in HCC, but especially in metastatic disease. Thank you.